to Kinesiology Videos with Amara. Today we're going to be investigating a labrum tear. The acetabular labrum is a ring of cartilage that surrounds the acetabulum of the hip, which is a ball and socket joint. It provides an articulating surface for the acetabulum, allowing the head of the femur to articulate with the pelvis. The hip labrum acts as a shock absorber, joint lubricator, stabilizer, and pressure distributor. The anterior portion of this is most vulnerable when the labrum does tear. Tears can be due to a variety of things, such as frequent twisting movement, direct trauma, or degeneration. Causes include hip dislocations, repeated subluxations, slipped capital epiphysis, acetabular dysplasia, repeated athletic trauma, or femoral acetabular impingement, or FAI. An acetabulum labrum tear can also cause snapping hip syndrome, called coxa saltans, which results in a palpable inaudible snapping as the hip joint flexes and extends. A muscular imbalance of the pelvis can lead to anterior pelvic tilt and consequent pressure on the anterior labrum. Also, weak gluteals during hip extension has also shown to increase pressure on that anterior labrum. Femur or acetabular dysplasia can lead to femoral acetabular impingement, FAI, like we said before. Impingement occurs when the femoral head rubs abnormally or lacks full range of motion in the acetabular socket. There are 3 different forms of FAI, one of which we will pay particular attention to is when extra bone is present on that femoral head, which leads to the head being non-spherical. It may be possible to lower the risk of tearing your labrum by strengthening your gluteus, stretching before exercise, and discontinued use of repetitive twisting activities. So the first thing you're going to do for your clinical evaluation of a labrum tear is make sure you have permission to touch the patient. Then you're going to go ahead and gather a history, but before you do that, you want to make sure your patient is wearing minimal clothing. For a guy, this would look like gym shorts, and for a girl, maybe some spandex. When you're taking this history, you need to ask a lot of questions that help determine what kind of injury you're dealing with. For this injury, in particular, I have a friend who recently experienced a labrum tear, so I went ahead and asked him the history questions. He is a competitive soccer player who plays in a year-round team, and I asked him when his pain started and how long it has lasted for. Is there anything that makes the pain flare up? What kind of pain is he experiencing, and where exactly is it? He reported deep pain in his groin and even lower back. The pain was increased by running or general movement, and some days the pain was so terrible it immobilized him so he was unable to walk. After obtaining a history of the athlete and the injury, then you're going to observe the athlete. You're going to want to observe their legs and lower abdomen for any deformity or discoloration. Also, the athlete may have a foot that is turned in, implying anteversion of femoral head, or foot out, implying retroversion of femoral head, which hints at a malalignment of femur head in hip joint. And you also want to notice any limping, guarding, or limited gait, which may take place in order to minimize pain. So labrum tears are often misdiagnosed as common groin strains, and it is not uncommon for the diagnosis to be missed for many months after the labrum is actually torn. Some people experience no pain from a labral tear, but most will feel pain or an ache in their groin, like my friend, over the lateral hip or deep in their buttock region. Acetabular labrum tears often cause a feeling of leg catching or clicking in the hip socket as you move it, and it also may feel like your hip is locking up. With this in mind, we move on to the next phase of the examination, which is the palpation phase. This is always done bilaterally to compare the injured and non-injured side, but for today, we are just going to palpate one side. When palpating the structures of the hip, medial structures can be hard to differentiate against, but we know that we have our pectineus up here a little bit higher, and then also we have our adductor muscles such as adductor brevis, longus, and magnus. And lastly, we have the gracilis, which inserts down on the pes anserine. When looking at the lateral structures of the hip, you start with the iliac crest, which is where you classically would put your hand on your hip, the hip bone you can feel on the outside of your tummy. Then, stretching down from that, is your tentor fascia lata, which is going to extend from your ilium and down towards the leg. This eventually will thicken into the IT band, which inserts down on the lateral condyle of the tibia. Then you've got your gluteus medius, which covers and fans that side of the hip once again. And if you were to put your hand on your hip and lean your hip out, you can more easily palpate your greater trochanter, which is going to be the head of your femur and also has a trochanteric bursa on top. Next, you're going to go ahead and palpate the anterior structures of the hip. First off, you have the pubic bone, which is going to be in the center. It's that bone that you can feel the prominence between your legs. And extending from that to the anterior superior iliac spine is the inguinal ligament, extending this way. And now the anterior superior iliac spine, or ASIS, is going to be down from the ilium crest, that big bony prominence you can feel. And the anterior inferior iliac spine is going to be slightly inferior to that, another prominence just a little bit lesser. The sartorius starts at the anterior superior iliac spine and extends down the leg to insert down at the pes anserine. And the rectus femoris also originates at the anterior inferior iliac spine up here and extends down into the patellar tendon. For the posterior structures, you're going to identify the median sacral crest, which is commonly known as the butt crack, here, and then the posterior superior iliac spine, or the PSIS, the back dimples. And then what you're going to find is the sacroiliac joint, which is between the ilium, or the big prominent hip bone, and the sacrum in the center. It's going to be right on here near the PSIS. And then the ischial tuberosity, or bursa, is going to be your butt bone, classically the bone that sticks out when you sit down, right here. And then you're also going to identify the sciatic nerve, which is between the lesser trochanter of the femur and the ischial tuberosity, extending down through the posterior aspect of the leg. Then you also have your hamstring muscles that we've covered in other videos, and your gluteal muscles, or your butt. So the next part of our evaluation is the range of motion and manual muscle testing. First, we're going to check hip flexion extension, where our patient is laying supine and brings his leg up and back down. And then he's going to go over to prone. He's going to bring that same leg up to the sky and back down. Next, we're going to look at the abduction and adduction. So we're going to stabilize the opposite hip and have him extend his leg up and go across and away from his body. He has a good range of motion. We're going to check the internal rotation as the patient is supine, bends their knee, and points their foot out for internal rotation, and then goes ahead and points their foot in for external rotation. Last thing we're going to check is circumduction, where the patient is once again supine. They extend and point their toe out, lifting their leg off the table, and draw a circle one way and the other way, checking the circumduction. It's also important to do a lower quarter screen. This helps identify nerve root impingement or lumbar or sacral plexus, or associated nerve roots or piriformis syndrome. This is used when a patient has numbness, muscular weakness, or pain that is unexplained. Since each spinal nerve root innervates a very distinct area of skin, this helps pinpoint an injury and the possible cause as being part of a peripheral nerve or the central nervous system. It is important that your patient maintains a similar position as you palpate both sides bilaterally. And a rule of thumb when performing these manual muscle tests is that if only one muscle is weak, then it is most likely only the peripheral nerve involvement or muscular involvement. But if more than one muscle is weak, then you are not only thinking peripheral nerves, but maybe even nerve roots as well. Today, we are only going to be doing a touch test, but you also can do some muscle testing for each of these nerves. So for this myotome testing, first we're going to start with the L1, which is felt with the dermatome that reaches from the buttock and across the lateral thigh. Then L2 is going to be slightly below that, reaching a little bit lower. L3 functions for knee extension, so it's going to be down towards the mid-thigh. L4 helps with ankle dorsiflexion and extends down across the leg. L5 is great toe extension, coming down to the dorsum and the three toes. And then you have S1, turn around please, which is going to be the lateral calf, and S2, which is the medial calf. Next up are our special tests, which of course are done bilaterally, but for the sake of this video, we will just do one side. The most consistent physical examination finding for a positive labral tear is the positive anterior hip impingement test and the positive scouring test. When assessing labrum tears, we have to be careful because physical exam findings could be inconsistent, likely because of the variable locations of labrum tears, and often a tear is not properly identified for a long time after the injury takes place, so it might be tough to locate it in the first place. So the first two tests we're going to look at are the positive anterior hip impingement test. This is performed with a supine patient with the hip at a 90 degree of flexion, and the hip is going to be internally rotated with adduction force, and a positive test would result in pain provocation in the anterolateral hip or groin. And then we're also going to look at the posterior hip impingement test, which is done in the same shape while the examiner is going to passively extend, adduct, and externally rotate the hip. A positive test for this one reproduces anterior hip or posterior pelvic pain, and these tests are both used to diagnose FAI. So here we have our patient on the table. We're going to go ahead and have him bring his knee into 90 degrees of flexion. I'm going to do the anterior test first, so I'm going to internally rotate the hip and apply a force. And we're going to bring some flexion, look for pain. And then for the posterior, we're going to externally rotate and apply force through various degrees of flexion. The next test we're going to go ahead and do is a stitch field test, which tests for intra-articular hip pathologies. While the patient has their leg extended, they are going to go into resisted extension, so go ahead and push up against me. And if there's much pain from 30 degrees to 45 degrees, you have a positive test. The next test you're going to go ahead and do is called a log roll test. So the examiner is going to go ahead and take one of the legs and maximally internally rotate, as well as externally rotate one of the legs, and compare it to the other side. And what you're looking for is some popping or clicking, which is going to indicate a labrum tear. So the next test we're going to go is the piriformis test, where we're going to go ahead and stabilize the patient's hip, bring this leg into flexion of the knee, as well as about 60 degrees of hip flexion, and then we're going to go ahead and apply pressure down on the knee, checking for excessive piriformis tightness and pain, which may indicate an issue with your sciatica. The next test we're going to do is the Faber or Ford test, where the patient is going to go ahead and flex their hip, abduct their hip, go ahead and cross their leg over, and then you're going to see, with some pressure, if the leg is able to be parallel or flush with the opposite leg, or even be able to fall onto the table, which is a negative test. If it's a positive test, the leg will not be able to go down quite as far. And this would indicate iliopsoas spasm or SI joint involvement. The next test we're going to go ahead and do is the hip scouring test, where we're going to go ahead and have the patient in full hip and knee flexion, knee to chest type thing. We're going to go ahead and press down on the knee and scour both inwardly in a circle and then also outwardly in a circle. And then you're going to go ahead and do this at various degrees of flexion. Sometimes the circle can just go out or all the way in. And this is going to be able to help check if you have any deformity on your head of your femur and see if there's any issues inside that ball and socket joint of the hip. So as we said, that hip scouring test and also the anterior impingement test are really great tools to check for labral tears because they help figure out if there's femoral acetabular impingement, a labral tear, and anterior impingement, as well as defects in the articular cartilage of the femur or acetabulum. Once you've done all these tests, you should be able to differentiate the injury and decide you have a labrum tear. If you are a little bit nervous about maybe measuring leg length or something that looks off about the person's or the patient's physiology, you can go ahead and try the true leg length test, which may indicate some type of hip issues where you have a discrepancy in the distance from the iliac crest to the greater trochanter of the femur. If you have cox vera or coax vera, you have a decreased hip angle, which is less than 120 degrees, and this may shorten or cause a limp in your leg. Or you have coax valga, which increases hip and femur head angle above 135 degrees and may indicate a subluxation. Another one you could do is the Weber-Barstow method to test for asymmetry if you are so concerned about this. Now that you've completed your evaluation, you can determine that you have a labral tear. You can refer the patient to a doctor to give them an x-ray to check for bone deformity or an MRI to show the actual tear. And for treatment, you're going to want to rest from activity, do some NSAIDs and PT and exercises to help return strength and mobility once you've had enough rest. And since the labrum is somewhat avascular, movement helps get nutrients and healing going. You want to start with conservative treatments, and then if you need to, go to more serious ones such as surgery if the tear is intense. And after this, you might have 6 weeks of crutches, as well as 6 months to full recovery and being back in your sport. As in the case of my friend, he was diagnosed by an MRI. They discovered FAI as a bone growth on the top of his femur, and it was digging into his hip socket and tearing his labrum. Surgery was required to remove that extra bone growth and fix the labrum, and then there was a treatment plan of rest, PT, and some exercises, and vitamin D, and approximately a 6-month recovery before he was back on the soccer field. Go home. Get out of here. It's all done. It's over. That's it. Goodbye.